Good evening, everyone. Thank you for joining us. We hope this will be an educational and maybe entertaining discussion about the heterogeneity, therapeutic advancements, and updated guidelines for the treatment of relapsed refractory multiple myeloma. And I'd also want to say welcome to the audience who's viewing this on the live stream. I mean, you guys might have a little bit of FOMO on the live stream because we actually have Taylor Swift in the audience right now. That's why she's in Chicago, right? She's to attend our CME, right, Shan? Okay, so it's me, Andrew Yee, and Dr. Malin Cody, and then here are our disclosures for both of us. And this program is provided by HMP Education, an HMP global company, and it's supported by an independent educational grant from Janssen Biotech, administered by Janssen Scientific Affairs. So I just wanted to thank also HMP and Janssen for giving us the opportunity to talk about relapsed refractory myeloma as well, so thank you. So here are the learning objectives. I think the focus of tonight is to talk about treatment of relapsed refractory multiple myeloma, the new data that's emerged, how we approach different clinical situations, to think about the different mechanisms of action, adverse event profile, as well as think about how we can implement current and emerging antibody therapy strategies and protocols. I mean, there's a lot of text here to read off, but these are the learning objectives for tonight. Essentially, we're going to cover the nuts and bolts of how we think about relapsed refractory multiple myeloma. Okay, so let's get started. So I'll be your first speaker tonight. And so my half of the topic is to talk about treatment of patients with 1 to 3 prior lines of therapy, and to think about how do we make this practical for patients in the community. I think that's something I want to emphasize here, because you have all these exciting therapies that we hear about today. For example, just at today's oral session at ASCO, but a lot of those therapies, they're in clinical trials. They're not readily available. You have to go to a major medical center to access them. So I wanted to talk about what can you do today, right now, for patients who have relapsed refractory myeloma. And I'll cover these various agents of interest. And then I'll let my colleague, Dr. Malin Cody, talk about patients with 4 more prior lines of therapy. And he'll talk about some of the really exciting developments with BCMA targeted therapies, as well as non-BCMA targets. So here's a figure that just illustrates the dramatic improvement in outcomes in multiple myeloma. And it's part of the reason why, for me and Dr. Malin Cody, it's very satisfying to take care of, and gratifying to take care of patients with multiple myeloma, since we know that with the therapies we have available, we can really transform patients' lives for the better. So here, for patients who are diagnosed before 1996, the overall survival is 2.5 years. But fast forward, to about patients diagnosed about 10 years ago, the overall survival has tripled. And here in the figure, I try to illustrate that, when we use newer treatments, combinations of therapies that are better tolerated, you get deeper responses, and we can extend these responses with maintenance therapy. And so patients can stay on therapy longer. And then for patients who do relapse, it's very well possible that the therapy they have at their first, second, or third relapse could offer a better response than what they had initially, which is kind of provocative, right? And it just speaks to the development in myeloma. And so this figure illustrates really the flurry of activity that we've seen in approval of drugs really in the past 5 years. So we have, for example, the approval of selinexor, which has a completely new mechanism of action as an oral drug, as well as 3 BCMA targeted therapies, CAR T cells, or as a bispecific antibody. And then I kind of put in that box, it's possible that in it's possible that this year we could see approval of 2 more agents, another BCMA bispecific antibody, elranatamab, and then talquetamab, which would be a first-in-class GPRC5D bispecific antibody. So again, so much excitement here. So part of our job for me and Dr. Malin Cody is to think about how do we integrate all these therapies together. So the slide I put up here is kind of a generic slide here. There's nothing really there's nothing particularly insightful about this, right? Because this sort of applies to general oncology principles when we think about treating relapse disease. We think about patient-specific factors such as the patient's functional status, and also the patient's treatment history if they're interested in participating in a clinical trial. We think about disease-specific factors, such as, is this a biochemical relapse? It's a gradual rise of monoclonal protein or light chain. Or is it more of a clinical relapse where the patient has symptoms such as from a new lytic bone lesion or develops new cytopenias? We think about the tempo of the relapse. Does it occur early in their disease course, like say within a year of their initial therapy, or are they just cruising along on maintenance therapy for years and then they start to have a relapse? And then we start to think a little bit more about the biology of the disease. And we're starting to think more about like translocation 1114 and also potentially actionable mutations such as BRAF. And then we do think about the therapy-specific factors, such as just practical stuff. How is it given? Sub-Q or IV? The schedule. Does the patient have to go there once a week, once a month? Side effect profile. And also, what are the logistics involved? Do they have to have a caregiver around? Do they have to be hospitalized? So these are all key things that we think about for choosing a therapy. And so here it's sort of obligatory to put these NCCN guidelines. You have like a big laundry list of things to choose from, so it's kind of hard to put into context. And, do I have a favorite? Yeah, I mean, I think all of us do have things that we're more familiar with that we put higher above than other ones. But here it's sort of confusing when you see it. It's just sort of just put as one big pile. And, the Mayo Clinic also has an M-Smart algorithm too, actually, which I was just looking at. It's a lot less, it's a lot less busy and more streamlined. So here's, again, just to kind of be more specific, provide some data about thinking about biochemical versus symptomatic relapse. And the majority of the patients, when they have a relapse, it's a biochemical relapse. And I think that has to do with when somebody has myeloma, they're getting followed more frequently, right? You're checking, they show up in clinic, they get their SPEP, light chains monitored. You're checking them on a much more frequent basis. So more often than not, it's a biochemical relapse. So in the Mayo Clinic series, about 60% of them had a biochemical relapse. And then here you can see a distinction between patients who have a biochemical relapse tend to do a lot better than patients who have a clinical relapse or an aggressive relapse, which has extramedullary disease or even, say, plasma cell leukemia. So again, this is kind of intuitive, right? Nothing too profound here. And then also early relapse, it's associated with worse outcomes. And again, this is somewhat intuitive too, but I think this is just useful just to put some data down. So here, the Myeloma 11 study, they found that patients who relapsed within 12 months, their overall outcomes were significantly worse. And this happens to about 13% of patients. And this is after high-dose stem cell, melphalan stem cell transplant. But I think what's really eye-opening here, for me, when I look at this study, what's really eye-opening is that in these patients who had these early relapse, about 28% had standard risk cytogenetics. So it's not just like if you have standard risk cytogenetics, you're good to go. I mean, these patients can have early relapse and more complicated outcomes. So next question comes up, like when should the patient be treated? Should the patient be treated at biochemical relapse or symptomatic relapse? And I think everyone would agree if a patient has a symptomatic bone lesion, that the patient should prompt a change in therapy because you do want to do something to kind of the patient has something that is symptomatic. And then for the biochemical relapse, do those patients need to be treated? So I think this other Mayo Clinic study was really interesting in the sense that it showed that patients who were treated, they looked at patients who had a complete response and then had a relapse. And they looked at patients who were treated at biochemical versus symptomatic relapse. And you can see here that patients, this is overall survival. Their overall survival was significantly longer by about 40 plus months if they're treated biochemical relapse. And then when I was first looking at this paper, I was like, oh yeah, it's so obvious, right? Patients who have biochemical relapse, they're going to have more favorable, they're going to be all standard risk, and they're going to have like more favorable ISS stage. But what's interesting though, if you look at the table, the standard risk and the symptomatic relapse and the biochemical relapse, they're really not that much different in terms of their baseline characteristics. And another theme, I think, in myeloma care that I think becomes emphasized more as we have these, triplet, quadruplet regimens, is the idea of using your best therapy earlier due to loss of patients over time. So here is a study based on insurance data, these large databases, and it just shows you the risk of, the patient, there's like no time like the present, so to speak, or strike while the iron is hot, or I can think of some additional hokey aphorisms. But I think the point is that the patients may not always make it to the next line of therapy. So you want to give them the best therapy at that point in time. So here I just want to talk about a common scenario at first relapse, because this is a common clinical, because I remember I just saw a patient last week who has this exact same scenario. So the typical patient, let's assume for this scenario, the typical patient first relapse has had, a lot of people are using RVD as triplet therapy, and then followed by lenalidomide maintenance. And then some patients may or may not have had a stem cell transplant. So at time of first relapse, I would consider these patients the lenalidomide maintenance, lenalidomide refractory. And then, for the typical patient first relapse, the patient has not had prior anti-CD38 monoclonal antibody. I think that's going to change, though, because I think now there's increasing use of daratumumab for newly diagnosed patients. And, I think the proportion of patients who've never had prior CD30 will probably get smaller over time. But I think right now, in 2023, this is still a pretty typical patient. So the scenario that comes up would be, how you decide. I think my feeling is that if I see a patient at first relapse who has not had a CD38 antibody, this is the opportunity to use a CD38 antibody. So then the question is, what drug do you partner with? And I think this gets kind of confusing because of all these trials. You can combine with pomalidomide or carfilzomib. So how do you decide? So these are just some background slides. So pomalidomide, even though when you look at it side to side with lenalidomide, they look really similar. Like only a couple atoms are really shifted around, but they, even though they look so similar on paper, they have really different clinical activity. So one of the takeaway messages here is that pomalidomide is active in lenalidomide refractory disease. So this is an older study. It's not that exciting anymore, right? It's 10 years old. But I think the point of this study was that these patients had 5 prior lines of therapy. This was like pre-daratumumab era, right? Pre-CAR-T era. But they had 5 prior lines of therapy, and they're all refractory lenalidomide. And here you can see that they have a doubling of PFS when you add on pomalidomide in lenalidomide refractory patients. So for me, this is an argument that, even though it's the same drug class, they're the same IMiD class, pomalidomide has activity in lenalidomide refractory patients. And then if you look at an earlier, say, 2 prior lines, you can see that the response rate goes up from, say, 4 months to about 13 months. And then the Optimism study also is just another demonstration where here all patients had prior lenalidomide, 70% were refractory. And again, this is just another trial emphasizing that pomalidomide it has an important role to fill for patients who have lenalidomide refractory disease. And then, for example, another study like daratumumab with pomalidomide and dexamethasone in 1 to 2 prior lines, you can see here a PFS of almost 24 months in lenalidomide refractory disease. And I'll touch more on the study later on. Then let's think about carfilzomib, right? Carfilzomib and bortezomib, they're both proteasome inhibitors. They're both given differently. Carfilzomib is intravenous, bortezomib subcutaneously. They have different side effect profiles. But I think the takeaway message here, when I look at this study, is that carfilzomib is active in patients. It has more activity compared to bortezomib, certainly in refractory disease. I won't talk about newly diagnosed disease because that's a whole separate conversation. But for relapsed refractory disease, I think it's settled that carfilzomib can be more effective than bortezomib, based on improvements in PFS as well as improvements in overall survival. And here I kind of threw this slide in there, thinking about treatment of biochemical relapse or symptomatic relapse. So in this clinical trial, you can see across the board that patients treated biochemical relapse had significantly improved outcomes. But again, it wasn't randomized based on relapse status, but I think the patient characteristics are probably different. So let's talk about anti-CD38 antibody combinations. So here are 4 phase 3 randomized studies that look at anti-CD38 antibody. So the 2 trials on the left is Apollo and Icaria. One was with daratumumab, the other one was isatuximab. They both use pomalidomide. The point here with these two trials on the left is that all the patients had prior lenalidomide and a proteasome inhibitor. And on the right panel, we have 2 trials with anti-CD30 antibody and with carfilzomib. And here, it's agnostic about prior lenalidomide exposure. And it had 1 to 3 prior lines of therapy. I also wanted to point out that the way that carfilzomib is given in those 2 trials, Candor and Ikema, it's given twice a week. And in current clinical practice, it's not really being done as much anymore. But I think it's useful just to have those slides as background. And then the MM014B, which I referenced earlier, and the ECLIS have studies that kind of more closely approximate current US practice. Because in the The one on the left, is just prior lenalidomide, and the one on the right is using carfilzomib weekly. So here I made this figure just to show the overall response rates as well as the PFS. So here across the board, on average, on balance, the carfilzomib containing arm has higher response rates, and it does have higher PFS, because if you look at the IKEMA ISA-KD, the PFS, at least in that study, was like 36 months. It's pretty substantial, and you can also see the response rates are higher. But I think when I was thinking about these studies initially, I was like, oh yeah, it's so obvious. These patients, Candor and IKEMA, only 40% of them had prior lenalidomide. And if anything else, I think the patient probably should have gotten like daratumumab lenalidomide, like Pollock style, right? I'm just saying that they never had prior lenalidomide, so perhaps that affected the outcomes of those patients and made those patients look more favorable. And what's interesting that if you look at the lenalidomide refractory cohort, granted this is a subset analysis, so the numbers are kind of small, but even in the lenalidomide refractory cohort, the Candor and IKEMA studies maintain their efficacy. So it's not just, oh, these were lenalidomide naive patients. But then, there's some differences in the adverse event profile. So, when I think about pomalidomide-based combinations, there's generally more neutropenia that can be associated with that. So as a result, when I'm using pomalidomide in these CD30 antibody combinations, in the trial they use 4 milligrams, but typically in clinical practice, I've been using 3 milligrams as a starting dose. And feel free to use a fair amount of G-CSF if needed to support the patients. And then with carfilzomib, there's concern for heart failure and patients being short of breath. But I would argue that in current clinical practice in 2023, am I seeing that degree? I'm just not seeing that in current clinical practice. And I think that reflects the shift to using weekly carfilzomib, say 56 milligrams per meter squared. Do you have to go to 50? No, you don't have to go to 56 if you're concerned about patients' tolerability. I think just the weekly dosing and the prior carfilzomib package insert talked a lot about hydration, but that's been de-emphasized. So here's one, approach to clinical practice. I'm not saying it's the approach; it's just one approach. And I think no one's done a head-to-head trial of carfilzomib versus pomalidomide with a CD38 antibody. I don't think that will ever happen. But I don't know. I think if you had to do a head-to-head trial, I would probably argue, maybe the carfilzomib might be a little bit better, just based on the subset analysis. I don't know. Maybe Shan might have a different opinion, but I think probably might be a little bit better. But there are other factors that go into this. Right, so I think the schedule of like Dara sub-Q, Dara, was given intravenously before it was approved in 2015, and the subcutaneous formulation came out. So we had COVID, and then we had Dara sub-Q, right? So it kind of balanced. No, didn't balance it out, but the fact that for me the Dara sub-Q has been a game changer, and I think because of that, in terms of the convenience aspect of it, that really, tilts it. Is in favor of Dara sub-Q with PomDex. So I think, for the patient, the typical patient who has a biochemical relapse who's asymptomatic, it's just a gradual rise in M protein. You've been looking, it keeps going up, and thinking, maybe we should do something at this point. I tend to use like Dara PomDex in that patient population. Now, in some patients, I think Dara monotherapy works awesome too. Like Dara monotherapy sub-Q, probably the easiest drug to use in multiple myeloma. Other patients, maybe PomDex could be an option. I didn't mention ixazomib. That could also be for patients who want oral option. You could think about ixazomib or selinexor, for example. We'll talk a little bit about selinexor later on. And then for the patients who have a symptomatic relapse, I think I would favor using an anti-CD38 antibody with carfilzomib, just based on that data. So in practice, again, lower dose, I think 3 milligrams can be really helpful. Using G-CSF, so patients, if they're neutropenic, I wouldn't abandon pomalidomide to become neutropenic. I would, try to maintain them on G-CSF. They might need further dose reductions. And then dosing of carfilzomib, is, I think weekly dosing, and I think, they did use 70 mg per meter squared in Candor, but typically, I've been using like 56 mg per meter squared, because I think in general patients tolerate that better than the 70 milligram per meter squared. You just need to see a response, right? And then you just run with it. So I'm going to shift topics to now think about, the CD38 antibody refractory disease. How do you approach CD38 antibody refractory disease? So this is a study that's quoted, that's been referenced a fair amount, and it looked at 275 patients refractory to anti-CD30 antibodies. And they looked at, in this retrospective study, they found that the overall survival was 8.6 months. So that kind of set the bar for where do we go from there. And I would argue, and I think as Dr. Malancoti will speak to, I think the game has changed for these patients, right? It's completely changed. So, but that was sort of the starting point to work with. You look at this figure and it looks kind of like doom and gloom, but I think the field has changed dramatically since this study was published. So but in terms of practical things, like what can we do like right now today? Like when you return back home, like what can you do for your patient like today? And so I think cyclophosphamide can be a great partner in myeloma therapy. I mean, you don't really hear as much about cyclophosphamide because if you go to the ASCO convention booth, there's no booth for cyclophosphamide, right? And wouldn't that be amazing if somebody had like a booth? But yeah, there's no, so you never hear about it. But in this retrospective study, granted it's retrospective, small numbers of patients, and you can see that the carfilzomib alkylated arm tended to have better overall outcomes compared to the other treatment arms. So that was sort of a useful reference point. And this is a study that looked at KCD, so carfilzomib cyclophosphamide dex versus carfilzomib dex. And the study, it's actually recently been published, and it was just recently updated at the IMS meeting last year. So there are a lot of details with it. But I think what's interesting is just focus on the lenalidomide refractory cohort. So in the lenalidomide refractory cohort, you can see a significant improvement in progression-free survival. Again, they use 70 mg per meter squared, but I probably would use 56 mg per meter squared. So I think for a patient, like the stereotypical patients, I just said, I would use daratumumab pom-dex in a patient with biochemical relapse. So for the patient who's relapsing after dara pom-dex, I tend to use carfilzomib cyclophosphamide dex, because I think that regimen works pretty well for those patients. So I've definitely had patients, they didn't really respond, they didn't have any response to dara pom-dex, and you're kind of hoping you'll keep waiting for a response, and then it change, and boom, you get a response right away. So there's something about cyclophosphamide that can be really useful for this refractory patient population. I do want to point, if you do look in the weeds, like the overall cohort, the overall survival might not have favored the cyclophosphamide, but again, that was the overall cohort. It wasn't the lenalidomide refractory cohort. I'm just acknowledging that I am aware of that finding. And then, you can do cyclophosphamide combined with pomalidomide. So here's just another example of a randomized study. This is kind of an older study, right, from 2016. Again, pomalidomide cyclophosphamide dex. It's another useful option, because I think when you get to this point, you're just looking for options just to keep the patient going. Like maybe you're waiting for a slot to open up for a trial, or maybe you're waiting for an appointment or a slot to open up for CAR-T or some other new novel therapy. You're just looking to just get patients put some additional gas in the tank. And here's another example, daratumumab, cyclophosphamide. I mean, these trials get more complicated, but I guess the theme here is that cyclophosphamide can be combined with all these different options. Like CyBorD can be also useful too, right? I didn't mention that as well, because that's kind of an old school regimen. Cyclophosphamide, bortezomib, dexamethasone. And then selinexor. So this drug was recently approved, and I think what's really exciting about selinexor, it has a novel mechanism of action. It's an oral medication, and it inhibits XPO1. So XPO1 is this nuclear export protein, and it blocks XPO1 from sabotaging the cell, right? So selinexor blocks XPO1, and it keeps the tumor suppressors inside the cell, inside the nucleus, and prevents the oncogenic proteins from escaping the nucleus. So I think selinexor, I think of it as preventing these oncogenic pathways from taking place. So there was the STORM study that was published, in which got selinexor approved. And in that study, they were giving selinexor 80 milligrams twice a week. And here, again, this was a pretty refractory patient population. This is a triple-class refractory patient population. I think in some respects, this patient population is probably more refractory than any of the patients that have been described today at the oral session today at ASCO, right? And these are really heavily treated patients. And here you were able to see a PFS of 3.7 months. But I acknowledge, selinexor can be a challenging drug, because there is this GI side effect profile to be with nausea and vomiting. Because, a lot of our myeloma therapies don't really have GI toxicity, which is what makes, the myeloma drugs, relatively easy to give. But, selinexor does have that GI adverse event profile. But, the point of the study was to get the drug approved. Because in reality, in myeloma care, we do combinations. We change things. So for me, this was, version 0.9 of using selinexor. And so the Boston study was a randomized study that definitively confirmed the activity of selinexor. And so when you think about the Boston study, it's a lot of these studies in myeloma, it's like A plus B versus A. So of course, A plus B is always going to look better, right? That's no surprise. But here, I think the nuance here, it's actually half of A plus B. Actually, B's actually that's not the great analogy. It's like A plus X versus A. But here, it's like half of A, because the selinexor arm had half the amount of bortezomib. But here again, if you see the addition of selinexor, you see improvements in PFS and responses. But when patients are getting that relapsed and refractory, bortezomib, I'm not sure how much juice it has at that point. So typically, I haven't been using it. When patients get to be that refractory, I don't know how, because they're probably already refractory to bortezomib. They might already have peripheral neuropathy at that point. So bortezomib can be more challenging to use at that point. So here, STOMP has these they're not randomized studies. These are single-arm studies, but they demonstrate how you can use selinexor in a fashion that has efficacy in this refractory patient population, and also minimizes the adverse events. And I think the key message here is that the selinexor dose here, it's 60 milligrams once a week. It's 60, so it's much lower than Boston or in the STORM study. And similarly with carfilzomib, it's using 80 milligrams again once a week. Carfilzomib is 56 mg/m² weekly, but you can see, this triple class refractory patient population, it was like triple class 13.8 months. Another key way to make this regimen more user-friendly is to think about supportive care medications. So I think there's, olanzapine can be really great as an antiemetic that patients can take, before or shortly after each selinexor dose, as well as thinking about ondansetron and drugs in that family. And I think that's really mainly in the beginning, because as patients get used to it, the degree of nausea, if they have nausea, gets less. So finally, I wanted to talk about venetoclax. So venetoclax is another oral drug. It's a BCL2 inhibitor. And this is a drug that's already approved in CLL and AML. So this is a drug you can just prescribe right now off-label in myeloma, right? But it's a drug that I'm sure many of you are familiar with. And I think this is such the t(11;14) disease is such an interesting subtype of myeloma. So what is interesting in the background is that there was cell line data that showed that venetoclax that the cell lines that had translocation of the 11;14 were unusually sensitive to venetoclax. So in a clinical trial, they just used venetoclax as a single agent. There's no dex, single agent, response rate of 40% as a single agent. I mean, that's pretty legitimate. Another point to point out is that unlike CLL, there's no concern for tumor lysis syndrome. And patients get started at that dose from day one. There's no tumor lysis syndrome, unlike in CLL. So this sets the stage for a randomized study, the Bellini study. And the Bellini study has multiple layers to it. So here you can see that overall the PFS is improved, but the overall survival in all patients, not favorable for the venetoclax arm, right? It might have been a little bit worse. And that caused a lot of heartburn and head scratching, right? You have improvements in PFS, but the overall survival is worse. Now, if you looked at the t(11;14) subset, granted a really small number of patients, you can see a whopping hazard ratio of like 0.12, substantial improvement in PFS, and the overall survival is not adversely affected. So I just showed this as a case. So this is a patient I was involved with. I mean, this patient has just a young man with crazy refractory disease. This patient has been through the ringer. And who knows, he may have seen Dr. Matt. The patient's been through the ringer, right? And you can see that in 2019, the free lambda light chain was like 1266, and then he starts venetoclax with carfilzomib, and you can see just within a couple weeks, the light chains just plummet down. So again, in the right patient population, this drug can be extremely effective. So there's an ongoing study. No, it's not FDA approved yet, so what I'm talking about is off-label. But in terms of for access to it, it hasn't been that challenging in terms of for routine standard of care, even though it is off-label. But there is an ongoing randomized study, CANOVA, that will definitively answer the question of the value of venetoclax in translocation 11;14. And the control arm is POMDEX. Now, in clinical practice, I tend to use it more with carfilzomib or daratumumab in clinical. Certain select patients, maybe I might just do venetoclax by itself. But I think this is an important drug to consider. So whenever I see a patient who's referred to me for relapsed disease, I kind of want to know, does the patient have translocation 11;14? Because they have translocation 11;14, they could do, and that just buys them more time, right? And it also just emphasized the importance of getting myeloma-specific FISH at time of diagnosis, because you have to use myeloma, otherwise you can miss this translocation, which is present in about 15% of newly diagnosed patients, ballpark. So here I just wanted to emphasize, that CD38 antibody, I think CD38 antibodies have been a game changer in myeloma. I think they work great with carfilzomib or pomalidomide. Choice, you can't go wrong with either choice, right? There's no bad choices here. But sometimes there's some choices might depend on the patient sitting in front of you. Cyclophosphamide can also be great too as another option, just again, to get a response, to buy time, and some patients, they can be on this regimen for years, right? But I think you just don't hear as much airtime, because you're not gonna see an advertisement at ASCO for cyclophosphamide. And then selinexor is also another really useful oral drug. I think the key is that to think about dosing of selinexor supported medications and combinations is really how you unlock the efficacy of selinexor. And then for patients with translocation 11-14 disease, the venetoclax can be a really useful therapy. So thank you. And I'll pass the podium to Dr. Mountcody.
Thank you. Thank you so much. So I'm going to talk about a newer immune-based therapies for multiple myeloma, relapsed and refractory myeloma. This, as Dr. Lee alluded to, there's been a lot of excitement and activity, particularly in the last 5 years, multiple new approvals, many more that are expected in this year, next year. So there's a lot of data to cover for patients with advanced multiple myeloma. So we're going to talk about clinical data for recently approved BCMA-targeted therapies, and there are 3 currently that are approved for patients with 4 or more lines of treatment. 1 bispecific antibody, that's teclistamab, and 2 CAR T cells, that's ide-cel and cilta-cel. We'll briefly touch on other approaches to targeting BCMA, for instance, allogeneic CAR T cells, off-the-shelf CAR T cells, and then focus on alternate targets, GPRC5D, for which, as Dr. Lee said, maybe we'll have a drug soon, and FCRH5 is another target that's being looked at as well. A few thoughts on mechanisms of resistance, next steps of where these treatments are moving, and future directions. So this is a slide, somewhat similar to what you saw earlier, different way of looking at it, just showing outcomes of patients with multiple myeloma over the years from the 1960s to 2020s. You can see 5-year survival that has progressively increased, particularly in the last 15 or 20 years, and that's largely related to new treatments and drugs becoming available for myeloma. And this slide here just looks at some of the emerging immune therapies, and this was just put together 3 years back. And I'll say already quite outdated, with some of the drugs fallen by the wayside. For instance, checkpoint blockade, which is listed here, we no longer use as much in myeloma. Many of the CAR T cells that are emerging have already emerged. They are FDA approved. Some that are not listed here are in clinical trials, new targets coming along. So again, highlighting how quick progress is in drug development for multiple myeloma. So most of you here are familiar, but this is a very simplistic cartoon for what a CAR T cell is. So this is a 2nd generation CAR T cell. These are the ones that are FDA approved for lymphoma, myeloma. They have an antigen binding domain. In the case of myeloma, the 2 available CAR T cells target a protein called BCMA, or the B cell maturation antigen, that we think is present in very high proportion of myeloma patients. Depending on samples and where studies are done, 95 to 100% of patients express BCMA, at least in a subset of myeloma cells at baseline, making it a good target for a treatment target for multiple myeloma. So in addition to targeting the antigen, the CAR receptor has a couple of additional parts to it. For instance, most CAR receptors have a co-stimulatory domain, as well as a signaling or activation domain, which allows for these CAR cells, T cells, to work against cancer cells in an HLA-independent fashion. They don't need to have an functioning HLA system. They're able to seek out BCMA-positive cells in the case of myeloma and get rid of these cells quite effectively. In conjunction to looking at CAR T cells, there's a different approach to targeting the same tumor antigens, called the bispecific antibodies. So this is an alternate approach, an off-the-shelf approach, a drug approach, again targeting, on the one hand, tumor-specific antigens, for instance, BCMA, and that's the one arm of the bispecific antibody. The second arm binds typically to CD3, which is present on the T cell. So these also try to redirect patients' T cells and go after multiple myeloma. So both of them co-opt the T cells in different ways, one with engineering by taking T cells out of the body, engineer reintroduce. The other one is to put in a drug that redirects the T cells. But both of them ultimately lead to T cell mediated anti-tumor activity in patients with multiple myeloma. So as I mentioned, we have three different BCMA-directed therapies that are approved for patients with 4 or more prior lines of treatment. All 3 are approved based on phase 2 studies, not randomized studies. So these comparisons are from 3 independent phase 2 studies, so they're not meant to be compared side by side because there are different patients, different trials done at different places, but helpful to kind of put them all, I think, in the same slide to just look through what are the common features between the different products and trials. Again, all of them target BCMA. So as shown here, these are the baseline characteristics for the 3 phase 2 studies. They're pretty comparable overall. 2 things that stand out, I think, is that the extramedullary disease and high-risk cytogenetic patients were slightly overrepresented with ide-cel compared to the other 2 products. And that's important because, as we know from many trials over the last 15 or 20 years, so anytime you have a new treatment or drug, patients with extramedullary disease and high-risk cytogenetic patients are the ones that don't tend to benefit as much as other categories of patients. Otherwise, pretty comparable. The median age was 60 years. You can see that with teclistamab, which is the off-the-shelf, patients all the way up to 84 years were able to go on the studies, on clinical trials, and get these treatments. Median prior lines, 5 to 6 lines, so pretty comparable. These are advanced multiple myeloma patients, many lines of treatment. And the majority of patients were what we would consider as triple-class refractory. That means they'd had treatments with at least 1 proteasome inhibitor, 1 immunomodulatory drug, 1 CD38 antibody, and were refractory to 1 of each. And that's about three quarters or more of patients in each of these treatments. So these are patients who, as Dr. Lee showed in some of the real-world studies, have an expected response rate of 25-30%, have an expected PFS of 4.5-5 months, have an expected overall survival of 8 to 9 months with conventional standard of care treatments that were available 5 years back because they've already received the other 3 classes of drugs. Adverse events. So the 2 class effects for BCMA-directed immune therapies, CAR T cells and bispecific antibodies, would be CRS and neurologic toxicity. So CRS, or cytokine release syndrome, we see in a high proportion of patients with either the bispecific antibodies or CAR T cells. As shown here, somewhere between 70 to 95% of patients will have CRS. So for those of you who are not as familiar, CRS would be mostly presents as fever. So all of these patients typically have fevers within a few hours to days of getting these treatments. And in a proportion of patients, you would see more signs of inflammation like low blood pressure, low oxygen levels, sometimes effects on kidney, liver, etc. So that's here listed as grade 3 or higher events, which are actually quite uncommon. In these 3 products, it's between 1 to 5% rates of grade 3 or higher CRS. Neurologic toxicities, again, there's a typical neurologic toxicity that comes with these treatments called ICANS, or immune effector cell-associated neurologic toxicities. These tend to be presenting as difficulty with word-finding difficulties, confusion, lethargy, and in extreme cases, I guess, lack of responsiveness and seizure-like disorders. Fortunately, neurotoxicity is lower rates with BCMA-directed therapies. For instance, compared to CD19 CAR T cells, only about 20% of patients have neurologic toxicities after CAR T cells and bispecific antibodies for myeloma. And high-grade neurologic toxicities are even lower, between 1 and 3% for teclistamab and ide-cel. With cilta-cel, there is a higher rate of grade 3 toxicities because there does appear to be a signal in some patients of having a delayed neurologic toxicity in the form of Parkinson's-like symptoms or cranial neuropathies of nerve palsies that have been seen in some patients with cilta-cel with advanced disease. Although I think as patients are being treated earlier with lower burdens of disease, that signal does appear to be less prominent in some of the ongoing studies. And then the last point I made here was, although these treatments are very effective, as I will show in the next couple of slides, they do come with lots of challenges. CRS and neurotoxicity are the two common ones. But in each of these products, you can see a good proportion of patients do die from non-relapse related causes, infections being one of the big concerns for some of these patients. Management of CRS and neurologic toxicities is another concern. So these are treatments that are highly effective. They do have toxicity challenges that I think we're getting better at managing as we learn more about these treatments. So what about efficacy? Again, I'll remind you from the previous slides that the bar for myeloma 5 years back was to have a drug that had a response rate in about 30% of patients. That was considered as a good response for relapsed and refractory multiple myeloma. If you had a single agent activity of about 30%, that was considered very, very good. That's no longer the case. As shown here, the overall response rate for these BCMA-directed therapies as single agent in patients with 3 or more lines of treatment is somewhere between 63 to 98%. Cilta-cel actually is 98 at update. So that's CR rates, the overall response rate. Coming to complete response rate, that number is between 33 to 82%. Again, the Cilta-cel update is now 82% complete response rate. So we're talking about drugs that have not an overall response of 30%, a complete response rate, a single agent in relapsed refractory multiple myeloma, upwards of 30%, and with one product, maybe even approaching to 80+% of patients achieving a complete response. What about duration of response? As shown here, those patients who respond to ide-cel have a median duration of response of 10.7 months. With Cilta-cel, it is not reached. We will hear at this meeting what that median duration of response and PFS is, but it is expected to be close to 3 years, I think, based on the last follow-up. And teclistamab has a duration of response of about 1.5 years. And similarly, PFS shown here for the two that we have available is somewhere between 9 and 12 months. For Cilta-cel, again, the median PFS is not reached, is expected to approach close to 3 years at the time of, hopefully at this meeting now. So again, this I think changes how we think about new drugs and treatments for relapsed refractory myeloma. We're no longer happy with the responses of 25, 30%. We were looking for responses of 50, 60, 70, 80% a single agent, and quite durable responses reaching 1.5 to 2.5 years with some of these products. So these are the Kaplan-Meier curves for the two FDA-approved CAR T cells. On the left is ide-cel, and on the right is Cilta-cel. With ide-cel, one thing I would point out is the FDA has approved doses between 300 to 450 million, and there does appear in the trial to be a dose response. Higher doses appear to have more responses and longer duration of responses. On the right is Cilta-cel, showing again that 55% of patients are progression-free at 2+ years of follow-up. And if you have a CR with Cilta-cel, which is about 80% of patients, their PFS is even better than those patients that did not have a CR. So this is the data similarly for teclistamab, again from the pivotal study that was presented and published a little while back, looking at duration of response, overall survival, and progression-free survival, all of which are quite impressive. The PFS is 11 months. The duration of response and survival is about 1.5 years with teclistamab as a single agent for patients with relapsed and refractory myeloma. So we looked at then, this is just something we did. Over the years, we've had many patients who go on these trials. Unfortunately, as these Kaplan-Meier curves would show, while we do see deep responses, the majority of patients unfortunately do relapse and need additional treatments. So we collaborated with Mount Sinai, another New York-based institution, where between the two centers, we had about 140 patients who had gotten an autologous BCMA-directed CAR T cell on one or more clinical trials. And of these patients, we then said if they progress, what is the outcomes like? Can they get other treatments? What are the responses like when they go on to these other treatments? And what's notable here is these are patients with 4+ lines of treatment who have already gotten a CAR T cell, and some of them have then gone on to receiving 10 lines of treatment, and the median was two 2 lines. Now, granted, these are patients who are treated at 2 large academic centers in New York where they do have access to other clinical trials, et cetera. But it does show that even beyond CAR T cells, even beyond the BCMA therapies, there are other treatment options. And some of these treatment options, as shown here, can provide deep and durable responses. This is looking at the median progression-free survival to the first line of treatment after CAR T cell progression. And the median PFS is a modest 3.5 months for all comers. But if you see patients who went on to receiving another immune therapy, another T cell engaging therapy, either a bispecific antibody or a CAR T cell targeting BCMA or the antigen, their PFS is now 9.1 months after CAR T cells. And this is median overall survival, again, for all patients who went on to receiving another treatment after progression from CAR T cells, it's about 1.5 years. They were alive for about 1.5 years after they progressed on CAR T cells on average. And then if you looked at patients who got a T cell directed therapy, that is a CAR T cell or a bispecific antibody, their median overall survival was not reached. And we had a fair number of patients, about 35 patients, who were able to get more than one T cell engaging therapy. And those patients tended to be the best. Now, again, I don't want to overemphasize this point because there are many caveats. These are from 2 select centers. Many of these patients were eligible to go on to other studies, which is why, and as you can imagine, patients who are eligible to do other trials tend to have better survival, but still does highlight that all those caveats notwithstanding, patients can move on from one T-cell engaging therapy to another and derive durable benefits and responses. So what's next for these treatments? With particularly the CAR T cells, we expect both cilta-cel and ide-cel to be moving up to earlier lines of treatment. As mentioned, current approvals are for patients with 4+ lines of treatment. Already, we have data from ide-cel where patients were randomized to receive either ide-cel or one of 5 standard of care choices in patients with 2 to 4 lines of treatment, and the ide-cel treatment demonstrated improved progression-free survival compared to the standard of care choices. Cilta-cel will hear as a late-breaking abstract at this meeting patients with relapsed and refractory myeloma with 1 prior line of treatment, 1 to 3 prior lines, looking at cilta-cel versus 1 of 2 daratumumab-based combinations. And again, we know from the top line results that the progression-free survival is better with cilta-cel, but the late-breaking abstract should provide details on how much better and the pros and cons, the efficacy, the toxicity profile, safety, etc. But this is from KarMMa-3, which is the ide-cel study, which is already presented and published, and I just show here the progression-free survival study. So again, KarMMa-3 was a randomized study. This is for patients with at least 2 prior lines, no more than 4 lines, so slightly earlier lines of relapse. Notable, though, that almost all patients had daratumumab and an IMiD and a proteasome inhibitor. This is triple-class exposed patients. And in this group, patients were randomized to receive either CAR T cells or one of 5 different standard of care choices. So the treating physicians had 5 different regimens, many of which Dr. Lee covered here a little while back. And this was an intention to treat analysis in the sense that everybody that was assigned a CAR T cell was counted for progression-free survival, whether they got the CAR T cell or not. One of the concerns with CAR T cells is that 10% or so of patients who get enrolled on or assigned a treatment may not be able to get the treatment because of the 4 to 6 weeks, 8 weeks it takes for these CAR T cells to become available. So a randomized study would level the playing field to some degree by counting anybody who is assigned to a treatment for those outcomes. And if you look at the data here, the median progression-free survival for ide-cel on this intention to treat analysis in patients with 2 to 4 lines was about 13 months. With the standard regimens, about 4.4 months on average for one of these 4 regimens. Now, there's a lot of commentary about the regimens of choice, the control arms, the patient selection, etc. But this is a pretty significant difference in progression-free survival for a randomized study. And it's the first of the randomized data for CAR T cells in multiple myeloma, looking at clear clinical advantage of doing CAR T cells earlier compared to some of the standard of care choices. And like I said, the cilta-cel data for a similar but different study because it's looking at even earlier patient population, 1 to 3 prior lines, some of them not even exposed to daratumumab, and compared to standard of care regimens, again, as per early results, we know that the progression-free survival is better, but the magnitude of the benefit will be, I guess, clearer after the late-breaking abstract at the meeting. So then what about other bispecific antibodies? So I have not listed all of them here. There are several more, but I have listed the ones that are farthest along. Teclistamab, we already saw, it's FDA approved. But the next two that I think are close by are elranatamab and ABBV-383, which is lenvaseltamab. And these are all BCMA bispecific antibodies. They do the same things. They target BCMA on myeloma cells, CD3 on the T cells, redirect T cells to myeloma cells. What's the difference? I'd say one is route of administration could be different. Some are sub-Q, some are IV. The frequency at which we give these drugs may be different. Teclistamab is currently approved as weekly dosing. Elranatamab is also studied as weekly. The ABBV-383 product actually is given IV, but every 3 weeks, so even less frequent dosing intervals. All of them are studied in patients with advanced multiple myeloma, and very a high-level overview of efficacy and safety would suggest that the rates of CRS, rates of neurologic toxicities appear comparable with these different bispecific antibodies. The same is true about response rates and overall survival, all the other metrics of efficacy also appear comparable. In the near future, I think we'll be having more than one BCMA bispecific antibody available, hopefully 2 or 3 or 4. And which ones we use and how we use them will somewhat depend on ease of administration, availability, access, cost, other factors that might favor us, lean us towards using one more than the other. I'm not entirely sure that efficacy or safety will be very different or will be the deciding factor for which of these treatments we'll use moving forward. So I guess shifting gears a little bit, allogeneic CAR T cells. So what are these? I guess we talked about CAR T cells, and all of the data we have for CAR T cells now are autologous, which means that we collect T cells, take them out of the body, engineer, reintroduce. That whole process can take somewhere between 4 to 8 weeks. It's cumbersome, labor intensive, not easily accessible, lots of challenges. Then we talked about bispecific antibodies, which are not cellular, and therefore not a one-time treatment. You do need to give the bispecific antibodies on an ongoing basis, weekly or every 2 weeks or every 3 weeks. But they are off the shelf, so you don't have to wait for them to be manufactured. You take them out, off the shelf, administer, etc. So allogeneic CAR T cells, in my mind, fall somewhere in between, in that it is off the shelf, but it's also one time because it's a CAR T cell. So the advantage is that because this is off the shelf, using donor cells, you can bulk manufacture cells and therefore allow for repeat dosing. You don't need to give any bridging therapy. The quality of the cells hypothetically may be better because these are from healthy donors, healthy T cells collected from healthy donors. But historically, there are 2 challenges with allogeneic CAR T cells. Number one is graft versus host disease. Those of you who take care of patients who get allogeneic transplant are very familiar with GVHD. The same concept of using donor-derived T cells, you'd be worried about graft versus host disease. And one of the ways in which that has been overcome is by knocking out the T cell receptor gene in the T cells, thereby abrogating graft versus host disease. The second challenge is the opposite problem, which is that the host immune system, that's the patient's own immune system, T cells and K cells, B cells, might reject these new donor-derived T cells and prevent them from expanding and having an anti-myeloma efficacy. And again, there are different engineering and chemotherapy strategies that have been used to overcome the host versus graft issue as well. So this is the first of the allogeneic CAR T cells for multiple myeloma. It's called ALLO-715. It's a BCMA CAR T cell similar to the other CAR T cells we talked about, but instead of being an autologous product, this is an allogeneic product. So how do we go from an autologous to an allogeneic BCMA CAR T cell? By doing 2 additional changes to the T cells. One is to knock out the T cell receptor gene. This is in the hopes of abrogating graft versus host disease. And the second one is to knock out the CD52 gene, which allows in this protocol to use an anti-CD52 antibody as part of lymphodepletion, thereby trying to overcome the host versus graft issue. So the universal study was the first of the allogeneic CAR T cell trials for multiple myeloma. It was a phase 1 study, multi-center, and treated patients with relapsed and refractory multiple myeloma with different doses of ALLO-715, the CAR T cell, and different forms of lymphodepletion with fludarabine, cyclophosphamide, and the CD52 antibody called ALLO-647. The baseline characteristics are here. It's similar to the other data that I showed, relapsed and refractory, high proportion of patients with triple refractory, about half of the patients penta-refractory, median from 5 prior lines of treatment, so quite comparable to the other studies that we saw earlier. In terms of safety, CRS was seen here as well, but really mostly grade 1 and 2. There was one patient with grade 3 CRS. We saw some neurologic toxicity of about 15%, no grade 3 or higher events. And notably, we saw no GVHD. So it does appear that knocking out the T cell receptor gene quite effectively abrogates graft-versus-host disease, such that none of the 45 patients we treated, 42 patients we treated, had GVHD. But the opposite issue is when you use more lymphodepletion, you run into issues with infections, and that is something we saw in this study. About half of the patients had infections, 23% with grade 3 or higher infections, and 3 patients actually died from infectious complications across the entire study. And then because ALLO-647 is an antibody similar to other antibodies, there is a infusion-related reaction signal, although all very transient and low-grade and manageable. So what about efficacy? I guess there are many doses, but I'll focus the attention on 24 patients in the cohort who got the effective dose of 320 million with the standard lymphodepletion of fludarabine, cyclophosphamide, and ALLO-647. In that cohort, 71% of patients responded. 46% had what's considered as a VGPR, very good partial response. About a quarter of the patients had a complete response. And the duration of response was 8.5 months with a short follow-up. So this is just a swimmer's lane plot of the patients treated. And this is at the time of publication. But since then, for instance, the second patient is actually one of our patients who's out now 2.5 years with ongoing responses after one single dose of the allogeneic CAR T cell. So it's clear that there's activity. But again, in a very competitive landscape where we have so many different treatments, is 70% response rate acceptable, adequate? Do we want higher responses? How do we get more patients to respond, longer duration of responses? How do we lower the infection signal? Are all the ongoing or upcoming challenges, I think, for the allogeneic products. So shifting gears once more, all of the talk so far has focused on BCMA-directed therapies, and rightly so. We have 3 approvals, others that are coming along as we show. But again, as I highlighted, even with very effective treatments, unfortunately, patients do relapse, and the majority of patients will be expected to need additional treatments. So there's an interest to develop alternate targets, other approaches to targeting multiple myeloma beyond BCMA. And there are many different potential targets, some that are listed in this slide. Again, when we put this together, which was only about 3 years back, these were the ones being studied. Since then, many more have come along. The one notable thing that's missing here, which we'll cover in a few slides, is FcRH5, for which we now have a bispecific antibody in clinical trials. Well, I'll spend a few slides on GPRC5D, which is an orphan G protein coupled receptor. Its physiologic function is unclear. But independently at MSKCC and another group, I was identified as a possible treatment target for patients with multiple myeloma. Based on this data, this is from Eric Smith, my colleague, formerly at MSK, now Dana-Farber, looking at tumor samples with different tumor cell lines showing very high expression of GPRC5D in multiple myeloma, very limited expression in other tumor types. The second sets of slides, the figured bottom line here, is looking at normal human tissue. So obviously we want a marker that's present highly in myeloma, but you want to make sure that the marker is not present also in normal human tissue, so minimizing on-target off-tumor toxicities. And the nice thing about GPRC5D was it was primarily expressed in bone marrow, with some degree of expression in skin, nails, and hair follicles, and very little to no expression in any other tissue, making this a potentially attractive treatment target for patients with multiple myeloma. With the caveat that based on this preclinical data, we did worry that there might be an on-target off-tumor toxicity related to skin and nails and hair follicles, given the expression of the antigen in those tissues. So this is, again, mouse experiments from Eric looking at BCMA-negative tumors. These are mouse models of BCMA-negative tumors. When they're treated with a BCMA CAR T cell, as expected, because they're BCMA-negative, they don't respond. But if you give them a GPRC5D CAR T cell, these mice are cured of their myeloma, suggesting that GPRC5D-directed treatments, at least in mouse models, may have activity in mice that are resistant or refractory to a BCMA-directed treatment. So that work led to this clinical trial that we ran at MSKCC, which is the first GPRC5D-directed CAR T cell called MCARH109. So this was a CAR T cell study for patients with relapsed and refractory multiple myeloma. I'll point out that we did have a pretty inclusive eligibility criteria. We allowed for patients with prior CAR T cells. About half of the patients had had a previous BCMA CAR T cell before coming on this study. We allowed for non-secretory myeloma, who are often excluded from clinical trials. Prior allogeneic transplant was allowed. So And we treated a total of 17 patients across four different dose levels. We started with a very conservative low dose of 25 million, given that this was the first trial for this target, and went all the way up to 450 million. And again, if you look at the baseline characteristics, some of the things stand out. High proportion of patients with high-risk cytogenetics or extramedullary disease. 60% of patients had a previous BCMA therapy, either a CAR T-cell, a bispecific antibody, or an antibody-drug conjugate. And in fact, the majority of them had a previous CAR T-cell targeting BCMA. So what about safety? Again, CRS, as would be expected with an effective CAR T-cell, was seen in a high proportion of patients. Any grade CRS was seen in all but 2 patients. One of the patients, unfortunately, did develop grade 4 CRS, grade 4 ICANS, or immune effector cell neurotoxicity, as well as macrophage activation syndrome. This was the patient that was treated at the highest dose of 450 million, and also constituted a dose-limiting toxicity for that dose. We also saw 2 patients develop cerebellar disorders, again at that highest dose, again constituting DLT for that highest dose. I don't have time here to go through, but we do believe that it may be a rare but on-target off-tumor toxicity related to the expression of GPRC5D at a very, very low level in a part of the brain called the inferior olivary nucleus, somewhat similar to the Parkinson's-like symptoms that are sometimes seen in patients treated with BCMA-directed treatments as well. Apart from these, we did not see very many other things. The only other notable thing we saw was nail changes. 2/3 of patients had changes in nails, but we actually did not see much in the form of rash. We only had a couple of patients who had transient rash that very quickly reversed, and very little to no dysgeusia as well. What about efficacy? We saw 71% of patients respond, and this included patients both with and without prior BCMA therapies. So even amongst the patients who had a CAR T-cell, and this was their second CAR T-cell, we saw responses including complete responses and a bone marrow MRD negativity. This is just a PET scan from one of those patients, actually the first patient we treated. So being the first patient, he was treated at the lowest dose of 25 million, a dose that we were not entirely sure would be effective. He also happened to have a very refractory form of myeloma with rapidly progressing disease. And these are just, the top panel are just 2 examples of plasmacytomas that he had that was going into the treatments. And the bottom panel is a follow-up PET scan that was done 4 weeks later, showing pretty much complete resolution of pre-existing PET-avid lesions. And this patient eventually ended up having about a 9-month progression-free interval, at which point he unfortunately relapsed and had to go on to other treatments. And then shifting gears, I guess, that's the CAR T-cell, but in parallel, there's been a large clinical trial, a phase 2 trial, again, of talquetamab, which is a GPRC5D-directed bispecific antibody. So similar to the other bispecific antibodies, it binds to CD3 on the one side, the T cells. On the other side, binds to GPRC5D. And so thereby redirecting the T cells to GPRC5D positive cells. And these are the safety events. We do see CRS and neurologic toxicities, mostly all grade 1 and 2. But notable are these other toxicities: skin-related changes, dysgeusia, fatigue, nail-related changes. Remember, I mentioned a few slides back that there is expression of GPRC5D in these different tissues, and as expected, we did see on-target off-tumor toxicities in the form of rash, dysgeusia, nail changes, fatigue, and loss of weight and appetite because of loss of taste. There's also some GPRC5D expression in the back of the tongue, which leads to dysgeusia. So that does seem to be unique to this bispecific antibody compared to the BCMA bispecifics. And this is just the key efficacy slides. Again, talquetamab is given subcutaneously. There's a couple of different doses being evaluated, or 2 different phase 2 doses. One that's given weekly, 405 micrograms per kilogram. Another one that's given every 2 weeks, 800 micrograms per kilogram. The safety data looks pretty similar, as does the efficacy, as shown here. About 60 to 70% of patients, give or take, do respond to these treatments, and some of those patients have a complete response or a stringent complete response as well to the product. And this is just the swimmer's lane plot showing that we now have ongoing responses that are out 18 plus months in some patients who are on these studies, again, suggesting this is why we think that talquetamab may very well be the next novel treatment that becomes available for patients with multiple myeloma in the next few months. So this is just a summary of all the different GPRC5D CAR T cells that are in development or in clinical trials. And this was just put together a few weeks back, and I say it's already outdated because another study has been published a few weeks after we put together the slide. And it just, to me, it's a very amazing thing that GPRC5D as a target was first published in 2019. And we're in 2023. There are 5 trials here in phase 1 and 2. And like I said, there's a 6th one that's not included here. These are all patients that are being treated with clinical trials of this treatment. That's just in a matter of less than 5 years, going from a target that's identified in mice, in cell lines, to treating patients, to potentially getting the first approved treatment in a matter of 5 to 6 years. And what this slide shows is that all of these GPRC5D-directed treatments have responses, CRs. Their efficacy profiles are similar, suggesting that in the near future, more than one GPRC5D therapy may become more readily available for patients with relapsed and refractory multiple myeloma. So then, last few minutes, I guess I'll talk about cevostamab, which is another bispecific antibody. We already talked about BCMA bispecifics, GPRC5D. This is the third class of bispecific antibodies, this time targeting FcRH5, another B-cell plasma cell marker. And again, as with other bispecific antibodies, it binds to CD3 on the other side and redirects the T cells to FcRH5 positive cells. And similar to, continuing with the theme, similar to the other bispecific antibodies, you see responses in a high proportion of patients. About 56%, 57% of patients in this phase 2 study had a response. And the median duration of response was about 11 and a half months in this phase 1/2 clinical trial with multiple doses of cevostamab, suggesting that this, again, is another product, another alternate target that might in the near future become available more readily for patients with relapsed and refractory multiple myeloma. So lots of promising things, but I guess, are there challenges? I guess there are. So this is just some of the things that to be considered for CAR T cells and bispecific. So one big challenge with CAR T cells is they're still limited largely to specialized centers with access for apheresis, treatment, FACT accreditation, other things that limit its widespread, availability beyond larger centers. The bispecific antibodies, I say maybe in the beginning it does appear that these patients need to be monitored, etc. But several groups are coming up with creative ways to monitor these patients safely, effectively, such that I think it is feasible to do a lot of these treatment outpatient, and a lot of these treatment can be done across larger groups of sites and practices than CAR T cells. CAR T cells, again, need either inpatient or very close outpatient monitoring. With the bispecifics, that's probably true for the first 3 step-up doses because the CRS and the neurologic toxicity signal is really seen during the step-up phase. But beyond that, it's an outpatient treatment. What about CRS and ICANS? Again, slightly higher risk of high-grade toxicities with CAR T cells, less so, I think, with bispecifics, especially beyond the first 2 weeks of treatment. Availability, one of the big challenges, again, those of you who treat or refer patients or see patients will know, everybody is talking about long wait lists for CAR T cells, not being able to get the treatments as quickly as possible. So that's a challenge which I think is becoming better as more products are becoming manufactured, 2 different products in the market. But obviously, bispecifics being off the shelf have an obvious advantage. They're readily available, no wait times, no manufacturing. And that goes to the next point of the turnaround time. With relapsed refractory patients, sometimes it's very hard to come up with bridging therapies that keep patients stable for 4 to 8 weeks. That's not a challenge with bispecific antibodies. The efficacy I have here, I guess, again, head-to-head comparisons are challenging, but there are products, CAR T cells, that have a response rate of 98%, CR rates of 82%. With the bispecifics, again, high rates, but maybe not approaching that 98% rate. And cost, again, will need to be factored in. One-time treatment, ongoing treatment, they're all fairly expensive. How do we manage to get these treatments to all the patients who need them, especially as more treatments become available, especially as we consider that these are not necessarily curative and may need sequential treatments, etc. I think I'm going to very quickly go through this. It's a whole another talk, but why do patients not respond and stay in response? Why do people relapse? One of the common ways in which we think that, worrisome ways in which we think it happens, is loss of the antigen or decrease in antigen. The T cells may be exhausted, don't persist as long. Maybe it has to do with the microenvironment in those patients with extramedullary disease. And therefore, I guess we do need alternate strategies, other ways in which to target multiple myeloma. And one of the ways in which we and others are thinking about doing this is to target 2 antigens at the same time. So if BCMA is good, GPRC5D is good. Maybe if you combine the two, you'll get better responses. This is just mice showing that targeting both antigens together will provide better responses than any single antigen by itself. And then based on that, we have a trial at MSKCC for CAR T cells. Patients with relapsed and refractory multiple myeloma, we're collecting their T cells, making two populations of CAR T cells, one that targets BCMA, another that targets GPRC5D, and then co-infuse. So we're enrolling patients actively. And again, at this meeting, there's already a clinical trial and data published for patients that are co-treated with talquetamab and teclistamab, the two bispecific antibodies, one targeting BCMA, one targeting GPRC5D, showing that it's feasible and has responses and durable responses. So that's one approach, I guess, of targeting more than one antigen at the same time, whether with CAR T cells or with bispecific antibodies. So in summary, we now have two CAR T cells and one bispecific antibody targeting BCMA that's FDA approved. High response rate, promising duration responses for all of these therapies. Other options, allogeneic CAR T cells, more bispecific antibodies, alternate targets like GPRC5D. But relapses are common, and that's one of the big challenges. How do we tackle relapses? What are the mechanisms of relapses? And then I think the key areas for the next couple of years was going to be the potential to move these treatment to earlier lines, 1 to 3 lines, 2 to 4 lines, newly diagnosed myeloma, and the potential for combinations. How do we rationally combine, minimize toxicity with combinations, maximize efficacy? And with that, I wanted to thank all of my colleagues and collaborators, as well as our patients and caregivers. Thank you.
Well, thank you for a great presentation. I just had a question about the BCMA CAR T. When you showed the 3 different trials and the 3 different CAR T therapies, I understand that we can't compare like one study to the other, but the response rate to cilta-cel is like way higher than the other ones. How would you explain that difference?
Yeah, so it's a good question. So I will still caveat. I know it seems kind of repetitive to say we really should be careful about comparing trials. I guess this is something that all of us it's ingrained in our brains to not compare trials too much. And that is a good, good thing to have in the back of mind. As I mentioned, there are some differences in baseline characteristics. So, more patients with higher risk disease with ide-cel than cilta-cel. These are trials of about 98 patients with cilta-cel, 126 patients. So we're talking about relatively small numbers of patients. They were done in 2 different times. Ide-cel study was done a couple of years before the cilta-cel study, done in different sites and centers. So there may be various patient-related factors, logistical reasons. The very first CAR T cell studies, there's a long list of patients that were waiting, so the patients that went into those studies may not necessarily be entirely comparable to each other, even though by many metrics, the prior lines, all of those other metrics, they seem comparable. That said, your point is well taken, which is that the response, we're not talking about a difference of like 2% to 3%. We are talking about a major difference. So I guess 2 questions. One is, what might drive that difference? And I don't know that we know the answer. There are some structural differences, although both of them target BCMA, they're not the same product. For instance, cilta-cel, the scFv, that's the antigen binding domain, is derived from the animal llama. Ide-cel is murine. Is that sufficient to make a difference? Cilta-cel, the scFv, that is the antigen binding domain, can bind to 2 different epitopes in BCMA. Ide-cel binds only to 1 epitope. Is that sufficient? Not entirely clear. The second one is, do we really believe one is better than the other? I think we have to wait a little bit longer to know that. Right now, I would say in our practice, most of us would say whichever one is available for our patients would be the one that we would go with. Both have high response rates.
I'll follow up with maybe a more controversial comment, because I do love cross-trial comparisons, because, how could you not compare the trials and the different agents? And I completely agree with what Shyam was saying, and I think it also bears out in terms of the difference in the side effect profile. I think with cilta-cel, there is that late neurotoxicity, the Parkinsonism that hasn't really been as well described in the other CAR T products. I know in ide-cel they have started to see it, but not to the same numbers. But at the same time, realize that with cilta-cel, as people are using it more, maybe less heavily treated patients, the percentage of that is less. I think a couple other insights worth sharing, and I might be stepping out of my lane because
No,
Dr.
please.
Malincote's obviously the CAR T expert. I'm just kind of a hanger-on, right? But I think the real-world data, I think, is really interesting in terms of the real-world data for ide-cel compared to the KARMA study. I mean, the real-world data that's been shown for ide-cel, it shows that it did manage to hold its own, because my assumption would be in real-world data, the real patients have a lot more challenging to treat disease. They don't meet eligibility for various reasons. But the PFS for ide-cel kind of maintained it. I think what I'm really interested in seeing is the same analysis with cilta-cel. That's going to be presented on Monday, and we'll see what is the difference.
Questions?
Okay, so here we have some questions from the audience. Let's see here.
Oh, yes.
You want to take that one?
No, go ahead, please.
So to me, the most important prognostic feature in newly diagnosed myeloma is MRD. So it's like going from New York to Boston. It doesn't matter which way you get there. If you get to Boston, you're in good shape. But if you get stuck in Connecticut, you have a problem. You still need help. What do you see the role of autologous stem cell transplant today? Because it's really 19. I was a fellow when we were doing those things where you are right now. And it's a very crude thing. And some people get to MRD with the transplant. Some people get to MRD before the transplant, especially with the daratumumab and those therapies. So things have changed a lot, right, in myeloma. This is the checkpoint inhibitor therapy of hematologic malignancies. Everything's changed. And do you think we can have adaptive therapies so that we don't get stuck in Connecticut and get to Boston safely and hopefully live longer? Obviously, with all these new therapies, some of the ones you've described, some of the ones you have described, be those BiTEs or CAR Ts, you're certainly getting super impressive response rates and PFSs. You're no longer getting 30% response rates and PFSs of 4 months, which is what you would have got before. You're not getting marginal benefits. You're getting impressive stuff.
Yeah. So I guess you picked New York and Boston because it's Andrew and me. He's from Boston. I'm from New York.
Too. And my daughter is in New York, so I have to go from Boston to New York and vice versa.
But I guess we both should answer because I'm sure there's nuances to this question. But I can take the first stab. I guess you're mostly talking about newly diagnosed and the role of transplant in that setting, if I understand, or how as needs.
Frankly, to me, it's the role of MRD, whether it's in first line or
Sure.
even second line. If you push before we're doing things so crudely, you're following immunofixations. Now we have clonoSEQ.
Yeah, so I think your point is very well taken, that if you have a patient who's MRD negative, on average, you'd expect them to do very well. There are exceptions to it. There are patients who achieve MRD negative and relapse quickly, but by and large, patients who have MRD negativity, you would expect them to have a longer progression-free survival, longer overall survival, better outcomes. And you are also right that treatments like CAR T cells and bispecific antibodies have a high proportion of patients who achieve MRD negativity in relapsed and refractory myeloma. We hope that those same numbers will hold when you move earlier. Whether that means we can start to avoid, postpone, or eliminate transplant in a proportion of patients, I think we can start thinking about it. And I think that in at least if I were to take hazard, I guess I would think that in some point in the next 5 to 10 years, there will be fewer patients getting autologous transplant than there are today because of these treatments. Whether they will completely go away, I'm not entirely certain, for the reasons that while we do see very impressive responses, unlike CD19 CAR T cells, we're not necessarily seeing a plateau. In other words, a 3-year PFS is excellent for patients with 3+, 4+ lines of treatment. But unless we do better, a 3-year progression-free survival in the frontline setting may not be adequate, because we do have current treatments that can get us to 3 to 5-year progression-free survival for many patients with newly diagnosed myeloma. So the key challenge for these treatments to move earlier will be, will they perform even better than they do at relapse and refractory setting? And number two, some of the toxicity signals we see in 4+ lines of treatment are quite acceptable or I shouldn't say acceptable, but more acceptable in 4+ lines of treatment, because these are patients who otherwise do not have very many treatment choices. So when you talk about 1% risk of Parkinson's or risk of infections, opportunistic infections, I guess doctors and patients in 4+ lines may be more accepting of it because the efficacy is unprecedented. But those toxicities will be much more hardly scrutinized in patients with newly diagnosed myeloma, where transplant is a crude hammer, but we've gotten very good at very low toxicity, a very low risk of death or life-threatening toxicity with transplant. So I think the bar goes up for both efficacy and safety for these treatments as they move to earlier lines. So I think it's on us to, as we do these trials, to design trials smartly, to make sure that our combinations don't add to more toxicities, and that we do this in a stepwise, thoughtful fashion, as is being done. Start with 4+ lines, 1 to 3 lines, etc. But I do agree with the sentiment that based on how effective some of these treatments are, some or many patients may or may not need transplant in the future. For now, what I tell patients is if they are MRD negative in newly diagnosed myeloma or first line, and if they choose to collect their stem cells but defer a transplant, by and large, that's probably an acceptable choice. If they choose to do the transplant up front, in my practice, that's also acceptable. I would say, again, speaking only for my practice, about half of my patients chose to do upfront transplant after a long conversation with myself and the transplant doctors. About half choose not to or elect to defer to second or third line. I do tell them, though, that it's not a choice, or at least right now, not a choice between transplant versus no transplant. It's a choice between early versus delayed transplant, such that if their disease were to come back 2 or 3 or 4 or 5 years down the line, we would strongly consider doing transplant at that time.
Right. I think super controversial question. I mean, you could spend a whole hour and a half talking about that. And actually, I'm surprised 50%. But then again, I think MSK, the heritage, maybe not super pro-transplant, right, compared to some other institutions. So I think the transplant question, you ask 5 people, you get 5 different answers.
Yes.
And the reason why is because there's not really a right answer. And I think you can make arguments both sides, and I think you would be right. Because I think if you wanted to argue for the deferred approach, I would say, look, we have 2 randomized studies. You had IFM 2009, determination. Yes, PFS is substantially better. Yes, MRD rate is better. But even with those deeper responses, there's no overall survival improvement. So, so I can see most patients like, why would I go through all that, hang out in the hospital for 2 weeks, be out of work, and then there's no overall survival improvement. But on the other hand, if I want to be more pro-transplant, I argue, well, maybe there's something special about the transplant where maybe you're resetting the immune system. Maybe that's why Rev maintenance works really well post-transplant compared to non-transplant setting. Then again, there's some confounding because the patient population age is different. So I go both ways, and I agree with Dr. Malankody. I think we have this discussion because I do tell patients, if you want the deepest possible response, now's the time to do it. And some patients want that. They want to go all in. And I know this is recorded. I was going to make some jokes, but maybe I won't make. We'll talk. I'll have some jokes offline. So I think I support patients who want to do that approach. But for patients, it's like, I also support them that way too. So I kind of just read the body language and read the room and see what they want to do. I will acknowledge, though, and I think in the determination study, the PFS improvement in the high-risk patients was pretty substantial, and they didn't show overall survival. The overall survival data for the high-risk patients was not shown. So I do wonder, could you eke out an overall survival improvement in that high-risk patient based on the PFS difference was much bigger than it was in the standard-risk patients. It's interesting, Dr. Malankody mentions, collect the stem cells and then maybe we'll use them at time of relapse. But I think, what's the percentage of use? I mean, the determination was only a quarter of patients. And I think we're lucky in this, where Dr. Malankody practices, we just have so many resources available. I mean, he has this, dual targeting CAR T, right? I mean, you have access to that. So I think that changes the calculus of the value of transplant. Whereas if you're in a more resource-limited setting, the value of transplant becomes a lot higher.
So just to piggyback, I do think that it's important to highlight for patients that when they defer, it is deferring, not avoiding, because Dr. Lee is right that in the determination study, only about 20-25% of patients got transplant at the time of relapse when they deferred. So it was not really deferred because when second and third line came on, they went on to other treatments. And at least it's my bias that at least with current data, that is a disservice to patients, I think, because the transplant is an effective treatment. and one of many effective treatments we have available. And the best way we can keep this disease under check for the longest period of time for our patients to use all effective treatments in a logical fashion. So I do make it very clear to my patients that defer would mean that if their disease were to come back, we would very strongly consider doing a transplant at that point. And I would say for most people, at least we've done high proportion of patients at second or third line, when their disease comes back, they do go on to getting transplants.
Yeah, no, just to piggyback.
No,
we can keep piggybacking.
Yes.
And then we both couldn't carry each other. But it's interesting you mentioned, and not to throw just to throw a wrench in this, but once we have data from Karma 3. He just showed data in Karma 3 that ide-cel works great for patients 2 to 4 prior lines, and we heard data from about cilta-cel for 1 to 3 prior lines. So once those agents become approved, it will be interesting to revisit this discussion with Dr. Malancody when he sees this patient had cells collected. It'll be interesting. What does he actually do? Is he going to say, you know what, I'm going to put you in the hospital and give you a high-dose melphalan, versus, oh, you could do this, this CAR T, which, I think, yeah. So it'll be interesting to see how it plays out, and I don't think there's a right answer here, because you can have these discussions all night long.
Something I tell my fellows is the value of 5 years today is different from the value of 5 years in 2000 or in 1995. So the probability of getting breakthrough therapies in the next 5 years is a lot higher than the probability 7 years ago or 12 years ago. So the pace of innovation is huge. So when you give somebody 3 or 5 years, you're really giving them a lot more right now, a bigger chance of your double therapy or whatever the next therapy will be.
Right. No, I agree. I think in the myeloma field we've been exceptionally lucky to have, all the signs, the pharmaceutical partners really actively doing the trials to get these drugs approved. So I think we've been really lucky. I think. But then again, I'm biased because this is what we do, right?
Yes. Thank you.
So we have some other questions here. So I think we kind of talked about, TEC, ide-cel, and cilta-cel all have the same approval. This question comes up all the time. Can you talk about patient selection for these available therapies, and how also you think about sequencing with these agents in late relapse? Another controversial question.
Okay, so how do you select patients for these 3 treatments? I think one immediate treatment choice is somebody cannot wait for 6 or 8 weeks because this disease is rapidly progressing. They're not probably going to be, it's not doing them any service by trying to get them to CAR T cells. So wait time to get apheresis, then a wait time from apheresis to actual treatment itself, and that is probably not feasible for a proportion of patients. Those patients, I would favor taking them to teclistamab directly because it's an effective treatment. A good proportion of patients respond. If they respond, they do well. So I think that's one obvious way to decide between the two. Presuming that you have a patient who is more slowly relapsing or who can wait for a little while or who has a readily available CAR T cell slot, I guess, again, patients choose different things, I would say, my practice is biased, doing more CAR T cells than otherwise, but I would say many of my patients would prefer to get a CAR T cell with the advantage of it being one-time treatment and being able to be treatment-free for 12, 18, 24, 26 months, which is not something many myeloma patients have experienced. Many of them have had myeloma for 5 or 7 years and have been on ongoing treatments with maintenance, consolidation, what have you, for all these years. So the ability to be off all myeloma therapies for a period of time is appealing to many patients. So I think in that sense, a CAR T cell does have an advantage over bispecific antibody. In terms of sequencing, should we consider CAR after BiTE or BiTE after CAR? That's much more controversial. One way to think about it is if you have the access on trials, I would favor switching from one target to another. So if you had a BCMA therapy, perhaps think about GPRC5D, FCRH5, or another non-T cell engaging therapy. But if you don't have a choice and you're working with approved treatments, can you give more than one BCMA-directed therapy? Probably yes, at least based on small numbers of patients. It does appear that patients who get teclistamab after a previous BCMA therapy, about 45-50% of those patients are expected to have a response. The duration of response is more questionable, maybe not as impressive as BCMA-naive patients, and vice versa. We have published data from cilta-cel as well, looking at a small cohort of patients who had a previous BCMA therapy and then get cilta-cel. Again, a high proportion of those patients respond as well. So complete loss of BCMA does not appear to be the primary mechanism of resistance for the majority of patients, which means that many patients may benefit from more than one BCMA-directed treatment, with many caveats in terms of duration of response and some patients not responding, et cetera. But until we know better, I would say it's reasonable to consider more than one BCMA therapy for some patients at least.
Yeah, another piggyback, right? I think, all things being equal, this question, it gets really, there's so many layers to it. I think now in 2023, June 2023, I think the access to CAR T it just feels palpably different than it did a year ago. So the wait time for ide-cel, cilta-cel just isn't quite as long. The list of patients waiting for it's just not as long and stressful, I think. And, I would argue that, if I had a patient who was rapidly progressing, those patients, they may not be the best patient for teclistamab either. So it's, in my limited experience, since the drug's only been recently approved, I don't know how well patients do, because initially my naive thinking was, this is going to be, it has the same PFS as ide-cel, it's going to be just like ide-cel. But I don't get the sense it has the same efficacy as CAR T in that rapidly progressive patient. So for a patient who's rapidly progressive, I would probably think about temporizing them with salvage chemotherapy and then work on getting them lined up for CAR T. I think what is, really, and then the second question is how do you choose from cilta-cel? And that's a loaded question. I think just to answer the question, because people want to know, I think our practice, I think we have been having more cilta-cel slots available, so we have been using more cilta-cel. I think ide-cel does have a role, I think, for older patients, because just based on the toxicity profile, I think, for the older patient, maybe ide-cel might have more of an edge. But at the same time, I want to keep an open mind because we'll see what the real-world data for cilta-cel looks like on Monday. As a side note, I think, the oral presentation today with teclistamab and talquetamab I thought was really exciting. Granted, it's not, talquetamab's not approved yet, but the efficacy seen with those two bispecifics, because I think the reality of myeloma therapy is we're doing, aside from CAR T, we're doing combinations. That's just the nature of how we treat patients. And I think the efficacy seen with teclistamab, talquetamab, I thought that was really impressive, and that could potentially change, that decision, because I think, maybe in the same, if I had a rapidly progressive patient where I was like, I'm not so excited about teclistamab as a single agent, maybe I would do teclistamab, talquetamab in that patient instead of DCEP or something.
Yeah, I think.
Some other questions. Okay, this is another hot topic. With many using DARA newly diagnosed myeloma, what is the value of retreatment in the early relapse setting? So, right, I just presented a case, an easier case. I'm not going to present a hard case, right? So the patient, who is on, say the patient's on DARA, they're doing Griffin-style DARA RVD, or they're doing Maya-style DARA R, and then they relapse on DARA. I'm not sure, I probably would change gears up altogether, because my sense is those patients are they're refractory daratumumab, and I would think in those cases, I would think about Maya, maybe that would be a good time to get a proteasome inhibitor on board. I would think about POM, Velcade, Dex, bring optimism back into the picture, because the patient has never seen bortezomib. I think about, I think carfilzomib and pomalidomide play more of a role in somebody who's relapsing DARA-R. And I also think about, if we get these CAR Ts approved in early relapse, I think that would also be an option. Though, of course, Dr. Melancote wants to do high-dose melphalan for those patients, I think. Decided. But as another thing, I think, having said that, there are patients, in Griffin, patients are on Rev maintenance after a fixed period of maintenance with daratumumab. So there are patients who are going to be in Rev maintenance. And then, in Maya, not everybody's getting daratumumab until progression like the study. So I think if there's an interval of, say, 6 months where they're daratumumab free, that might be a good time to think about a CD38 antibody at that time. So that 6 months is sort of a ballpark. And we did hear data, looking at daratumumab kind of retreatment with teclistamab and talquetamab with talquetamab. So I think there is more data being generated for using CD30 antibody retreatment.
I think we're over by a few minutes, so
okay.
Thank you so much, guys. As you can see, there's so much data, we can go on for another 2 hours, but thank you everybody for joining, and we hope you will join us. I guess there's another talk tomorrow about BTK inhibitors. Thank you so much.